This video from Chapter 28 of OEC 6, Altitude-Related Emergencies, focuses on the prevention of altitude-related emergencies and the assessment of these conditions as well. So we'll look at Objective 28.4, Strategies to Prevent Altitude Illnesses. We'll look at signs and symptoms and specifically how to assess a patient who may have one of these conditions. So we'll encounter a couple of these key terms that we've seen before. We'll remind ourselves about HAPE and HACE and AMS, and we'll talk a little bit about some of the things that we see, for example, with sleeping altitude and acclimatizing. To prevent altitude illness, just keep in mind that health and physical fitness do not necessarily make you immune to altitude illness. Acclimatization is essentially the key. So there are some essentials we can follow, and one is just a gradual ascent, especially if you're going to be beginning at sea level and continue to above 10,000 feet. Layovers at intermediate altitudes can really help people who are traveling from sea level. And if you're traveling from sea level, a one-day layover, say in Denver at about a mile high, can really decrease the risk of becoming ill. Once above 10,000 feet, limit the increases in altitude to about 1,000 feet per day. And every couple of days, every couple of thousand feet of elevation gained, add an extra rest day. Avoid heavy physical exertion for the 24 to 48 hours immediately after your arrival, and really stay hydrated. And part of that includes avoiding alcohol, which can dehydrate you, has a diuretic effect as well. If you begin to show symptoms of altitude illness, don't go higher until the symptoms resolve. People acclimatize at different rates, so if you're traveling in a group, just make sure that everyone is acclimatized before going higher. And when possible, climb high and sleep low. The sleeping altitude has a lot to do with acclimatization. Now, when you take a patient history, just really be aware that there are some medications that a patient may have taken prophylactically to avoid altitude-specific illnesses. One of those can be acetazolamide or Diamox. The effects of this can be delayed, so a patient should begin using it 24 hours before ascent to altitude. Dexamethasone is a second drug that may be encountered, and that's used as in the case of an altitude illness, it's going to decrease swelling in the brain and some of the other structures, may reverse the symptoms of AMS, and that's because it is a steroid. It's going to reduce some of that inflammation. Certain ED drugs can also prevent altitude illness, typically we think because they're vasodilators. Adalat has also been used in the prevention of HAPE in people susceptible to high altitude illness. Now, specific to patient assessment, you really can't diagnose the underlying cause of a problem, but you can recognize signs and symptoms, and if it is an emergent condition, you can provide the necessary treatment. So always we begin with the ABCDs and some of the life threats that are there. If a potentially emergent condition exists, go with the life-saving treatment instead of the secondary assessment and some patient history. Make sure that we treat those life threats and call for ALS. Ask a patient about their medical history and symptoms using sample history, because here's where those medications will be found, and OPQRST. It's important to get after the onset and the severity of an altitude illness that may be occurring. Note in the sample history any previous or pertinent conditions such as cardiac or respiratory problems. This is one you may not think of, but individuals with sleep apnea can become severely hypoxic at high altitudes, so be sure to inquire about that. For a patient who's experiencing shortness of breath, we can talk about provocation or palliation, see if it's associated with any particular pain or if it persists during rest, and ask patients if they've ever encountered this before. Keep in mind some of the other symptoms that they may report include nausea and vomiting or excessive fatigue. We'll want to make the patient comfortable, and that's typically going to be an upright position that allows them to breathe more easily. Note whether the patient appears short of breath while they're resting, and assess for cyanosis. That's that bluing that we can see in the lips and the nail beds, and sometimes in the conjunctiva, which are the whites of the eyes. And we'll look for swelling or edema in the extremities as well. If a stethoscope is available, we can auscultate the lungs and listen for the possibility of fluid there, indicating pulmonary edema. If there's any visual problems, they'll notice a decrease in acuity. Complete your physical exam by palpating the body for areas of tenderness or swelling. Think about their skin temperature, circulation, and so on. And for patients who are complaining of symptoms that suggest AMS or cerebral edema, you can assess for ataxia by asking them to walk a straight line, heel to toe. If they're unsteady or unable to maintain their balance, it's possible that they're suffering from high-altitude cerebral edema. That requires immediate treatment. A serial set of vital signs, baseline and follow-ups, can really be important in tracking their progression during this illness.